Hi. Whilst I'm waiting, I'll introduce myself. I'm Sophie Eastwood. I'm a clinical epidemiologist, bingo, at UCL and a GP as well. I'm going to talk to you today about intersectional disadvantage in CVD preventative medication use. So let's start with sex, always a good place to begin. CVD is still the biggest killer in women globally. In the UK, it's second only to dementia, much of which shares common risk factors. And after the menopause, the protective effects of estrogen seem to decline quite quickly for women, such that by the age of 55 or so, rates of almost all CVDs are approaching those of men. Now, this seems to have been ignored for some time by the epidemiological community, but I'm happy to say in recent years it's become trendy, and there's been quite a few papers showing that women or that there are various sex disparities in different areas, especially diagnosis. Women tend to be underdiagnosed, and prognosis as well. So there's been relatively little research looking at sex differences in treatment, and that's sort of made the mainstream. These papers in circulation is focused around outcomes in secondary care, such as revascularisation. So if you're coming from my standpoint in primary care, I'd argue that prevention is much more important, and there's been relatively little research on that. So preventative medication use is an amazing thing. It can prevent up to 40% of CVD in people at high risk. I'm talking about primarily statins and antihypertensive treatments. They're free, they're readily available, certainly in the UK. So that's why it's really important, the disparities I'm about to show you in how they're actually used in the UK. So let's move on to ethnicity. Our work has shown major ethnic differences in who is prescribed treatment, who has the treatment optimised once they're on it. So if you have suboptimally controlled risk factors, we've got diabetes in here as well, who gets the medication stepped up or changed, and also who takes the medication in a regular and continuous fashion. And all those disadvantages affect primarily South Asian or African Caribbean communities compared to European ones. So why study intersectionality? Well, first of all, intersectionality is recognising that the disadvantages accrued from being in more than one social categorisation, and recognising the overlapping pathways that may lead to disadvantage. So we study it because it enables us to pinpoint exactly who isn't receiving the treatment they should get, and ultimately design and test interventions to try and ameliorate that. So what I'm going to present is some data we've generated looking at differences in antihypertensive and statin use by gender and ethnic group. So to do this, we used CPRD Gold, which at the time of the study had about 7% population coverage, and the population was people of recorded European, South Asian or African Caribbean ethnicity with incident diagnoses of hypertension requiring treatment or an incident indication for statin use. So we studied initiation and adherence for both sets of classes of drugs, and also blood pressure control for the antihypertensive analyses. And the results I'm going to present are by 6 different gender cross-tabbed ethnic groups. The comparator is European men in all the analyses, but as I'll try and highlight as we go through, most of these outcomes weren't optimal in that group either. They sort of assume they're the most socially advantaged in this respect, but it wasn't always the case. So let's start with hypertension management. So initiation, this was looked at in about 130,000 people with blood pressure above diagnostic thresholds who guidelines would recommend antihypertensive treatment in it And it's whether the outcome is whether they were prescribed antihypertensives within 3 months of the sort of ascertainment of indication. So if I just talk you through the plot, first of all, the comparator, as I said, is European men. That's this green dot at the top. And the estimates displayed that the ones on the left of the line are where the outcome's less likely than for European men. The ones on the right, where it's more likely than for European men. So I mentioned earlier that I haven't got the raw proportions of who was initiated in a timely fashion on the slides, but they weren't terribly impressive. Even in the group that was most likely to be initiated, which was African Caribbean men, only 30% of them had the treatment started within 3 months of indication. So let's look at the comparisons, and you can see, I hope, that for every ethnicity, women are being initiated on antihypertensives later than men. And it seems that there is an ethnic difference in the gender difference, if that makes sense. So if we look at the African Caribbean estimates, which are in blue, that gap between women and men seems to be wider for that group, and we can show some statistical evidence for that as well. So moving on to antihypertensive adherence, this is measured in EHR, I'm sure many of you know, by looking at gaps in prescriptions. So here it was the proportion of days in a year period where the person had prescriptions theoretically that could cover. And it's binarised into above 80% being adherent and below 80% being non-adherent. So again, just to mention, even in the best adhering group, which was European women, only 75% of those were adherent. So no one's doing particularly well here. So if we have a look, firstly for the sex differences, you can appreciate there's a small increase in the likelihood of adherence for European women at least, and a sort of vague smidgen of a suggestion of it for South Asian women, but no difference, no sex difference in the African Caribbean groups. What really stands out from the slide is the ethnic difference. So people of South Asian, African Caribbean ethnicity less likely to adhere than those of European ethnicity. And now, if we look at the most important of the blood pressure outcomes, which was whether someone met the target or not 12 months after treatment was initiated. And again, if we start with the sort of raw proportions, in the group that did the best was South Asian women, but still only 55% of them did meet the target. So overall, the picture is not rosy. We do see some sex differences. This time, sort of in men are more disadvantaged than women. So women are more likely to achieve the blood pressure control at a year than men for every ethnicity. You'll notice the ethnic difference as well. The likelihood of control is lower for the African Caribbean groups, and even the African Caribbean women, their likelihood of control is only the same as European men. So they don't seem to be experiencing the sort of female advantage, if you like, that the European and South Asian women have. So if we look at statins now, this was just in people with diabetes, but been involved in some other work which looked at populations without diabetes, which showed something similar, or exactly the same, in fact. So here's a time to event analysis, a median follow-up of 6 years, and we can see that the sex differences are less pronounced here. Possibly a suggestion of a non-significant difference advantage for the South Asian men versus South Asian women, but the other ethnicities are similar. And the real standout is the ethnic difference, with the African Caribbean groups less likely to initiate statins over the follow-up period. So if we look at statin adherence, calculated in a similar way to antihypertensive adherence, and with similar proportions of people, raw proportions not adhering. And here, again, there's a slight suggestion that women are more likely to adhere to statins than men, but the real standout finding is the ethnic difference still, rather than the gender difference. So just to conclude, I've tried to emphasise, even though the talk's about intersectionality, that in fact all societal groups appear to be managed suboptimally in terms of use of these medications. There was a longer time to initiation, certainly of antihypertensives in women, especially South Asian or African Caribbean women. The sort of general trend was that after you've had the medication started, your taking of the medication and your likelihood of blood pressure control seemed to be a bit better for women than men. However, this pattern wasn't so consistently observed for African Caribbean women. So I hope I've convinced you that it was worth taking this intersectional approach, so that we've identified this sort of double whammy of disadvantage, particularly for African Caribbean women in terms of use of these preventative medications. Okay, thank you for listening, and thanks to collaborators and funders.